Remo, and today we would be talking about the SAVR procedure, which is the surgical aortic valve replacement procedure. So now over to what we would be discussing. We would be talking about the background, indications for the surgery, the operative preparation, surgical approach, post-operative care, and recovery. So now over to the background. So what's an SAVR? It is a surgical procedure that is used to replace your aortic valve that may be weakened or injured due to any medical conditions or illness. This procedure lasts for about 15 to 20 years. It will support you, and after that, you would need a new surgery. So, what's the aortic valve? It is one of the four valves controlling blood flow to the heart. It separates the lower left heart chamber, which is the left ventricle, and the body's main artery, which is the aorta. And the aorta actually pumps oxygenated blood to the rest of the body, so it's quite crucial. So this surgery might be needed due to two medical conditions. One is aortic stenosis, and another is aortic regurgitation. We will be going over each of these. Aortic stenosis is basically when the valve does not open fully, and aortic regurgitation is when it does not close all the way. So aortic stenosis, as you can see, the valve is not able to close fully, and therefore the valve is narrowed. The stenosis is caused by valve leaflets that are thickened or calcified and fused over time. Pressure starts building up in the left ventricle, and this pressure starts damaging the heart muscles over time. The symptoms may include shortness of breath, lightheadedness, extreme progressive fatigue, especially when one is exercising, abnormal swelling in the legs or feet, and fluid buildup in the lungs in extreme cases. Aortic regurgitation is basically when your heart valve does not close tightly. It can occur suddenly or it may take decades to happen. The symptoms are usually shortness of breath again, fatigue, weakness, heart murmur, irregular pulse or arrhythmia, lightheadedness or fainting, chest pain or angina, discomfort or tiredness, sensation of rapid fluttering, heartbeat or palpitations, swollen ankles and feet again. As you can see, aortic regurgitation is represented on the right hand side by the image. Now let's talk about the epidemiological data. As you can see, it's aortic stenosis, one of the most common valvular lesions in the United States, and it has been observed during by CDC research that as a person age, they are more likely to contract aortic stenosis, and the younger population is not so vulnerable. There are alternatives to SAVR, and this is the TAVR or the transcatheter aortic valve replacement. It is normally advisable for the elderly because their heart muscles tend to be fragile, and once they are over the age of 60, this procedure takes only about 90 minutes. But there's the problem with this procedure as compared to SAVR. It is very short term, and the valve might only last for 2 to 3 years. The catheter is usually inserted as it is depicted in the image, and through the catheter inserted inside the chest cavity is guided to the heart for replacement, as you can see. Now, for the diagnosis, your cardiologist might do a physical examinations, and they might look for symptoms such as swelling in legs, fatigue and shortness of blood, and in extreme places, fluid-filled cases of the lungs. Imaging technologies might help. Echocardiogram, this happens through with the help of a transducer which is placed next to your chest cavity, and then the doctor will take readings and create images based on sound waves that are sent to your thoracic cavity. It might also happen. Color Doppler might also help. Color Doppler basically helps in determining blood flow in and out of the heart, and then ECG is always used to determine how the heart is beating. And the image to the right shows aortic stenosis, the echocardiogram picture of a patient suffering from aortic stenosis. And what are the indications for SAVR in children? It is most recommended if they have congenital heart failure in critical stenosis, which means they are symptomatic. In some cases, children might be asymptomatic, and symptoms might develop when later in life. And once it is detected early, they might not need the surgery. But when they show up as pale, hypotensive, and dysponic with approximately 50% having a normal pulse, and 50% usually have a normal heart sound. And then there's echocardiography, which shows a thickened or domed aortic valve with an increased Doppler velocity of greater than 1 meter per second. This is cases when SCVR might be needed. In adults, it is usually recommended for patients suffering from BAV or bicuspid atrial disorder, which means aorta valve disorder, which is instead of having three flaps, the aortic valve in these patients will only have two, and their aorta diameter should be more than 4.5 centimeter, and there should be no previous case of surgery, kidney disease, history, chronic obstructive lung disease, or diabetes. If they have such cases present, then a TAVR will normally be advisable. Now let's talk about preoperative preparation. The patient will have to fast for after midnight, and they cannot eat anything before the surgery or drink anything for that matter. They should stop taking blood thinning medicines such as cardamom, and they should stop smoking. Medications such as antibiotics or beta blocker might be prescribed by the surgeon. It depends on case to case basis. And then the surgeon will and the team would perform a full medical examinations, and they will look into the cardiovascular and respiratory systems. Uh, and then they will also check for any medical condition, and this is accomplished with the help of laboratory results, which might include blood work or complete blood count and urine tests to check any kind of additional complications. Imaging might also be used, such as computerized tomography, to determine how the surgery will proceed. Then after that, a general anesthesia will be given and several tubes will be prepared. This include a breathing tube, which is inserted into your throat and connected to a machine that helps in supplying oxygen and taking out carbon dioxide from you. A Foley catheter, which is used to empty your bladder, and the Swan's Ganz catheter, which is inserted in your neck, and it measures any kind of pressure that builds up inside your heart. The patient will be placed in a supine position, which means they will be lying on their back. And the incision site preparation usually involves removal of hair in the thoracic cavity. Surgical scrub would be used, and the patient will be wrapped with sterile towels. Now let's talk about the surgery itself. A 6 to 8 inch incision will normally be made down the center of the sternum of the patient. The doctor would mark the midline of the sternum, and the sternum will be divided across the midline. This is known as median sternotomy. The rib cage and lungs will be retracted on either sides. This is mostly done with the help of a retractor, and the sternal saw would be needed to cut the sternum. Marrow will normally tend to bleed in such cases because marrow is the place where blood is formed. The erythromycin is forming here, and therefore vancomycin is a type of paste that might be used to reduce the infection as well as help seal off the marrow. And bone wax is also helpful in such cases. A cell saver suction is used, and a retractor will be used to reveal the pericardium. The pericardium, once opened, will be opened with the help of incisions, and the doctor will also remove some of the fats that may be present so that they have a clear view of the aorta and the right atrium alongside the right ventricle. Now the doctor will use stacking sutures, which means that they will put sutures into the pericardium to lift it up so that all of these aorta would be visible. And output string sutures would be used to place in a number of cannulas. This include the cardiopulmonary bypass as well, which will serve as your artificial heart while the doctor surgeon works with your real heart itself, because your heart cannot beat while the surgery happens. And Teflon is normally used to support the aortic sutures, and a similar procedure takes place in the venous side as well. A syringe should be used to suck out air in the pericardium because there might should no be no air or any blood leakage in the pericardium, and a pump is sucker is normally used. It pulls any kind of blood leakage out of the pericardium, and after the surgery is done, that same blood will be filtered and uh, transported back to the patient. The last cannula that is used is the cardioplegia catheter, which is used to give a potassium-based solution to stop the heart. And it is up to the surgeon's discretion whether they should give one dose or they might give a continuous doses throughout the surgery. It really depends on the length of the surgery as well. Now let's talk about what happens after this. Clamping will normally be done so that the blood flows through the catheter, and cross clamp will be applied to the aorta. This acts as a valve and it prevents backflow of blood. There would be some ice put on your top of your heart so that it is protected and the heart muscles and cells doesn't die and they remain cold. A surgical transection of the aorta is done, as you can see over here, which means aorta is cut and to expose it, and a cardiophagia will normally be checked. The doctor will be checking if in the cardiophagia which was administered earlier would come out through the coronary artery or not. Leaflets of the aortic valve, which is calcified, will be removed by cutting, and they will be removed completely. And after this is the clearing is done and the cleaning is also done. A sizer is inserted to check the size of the aorta and determine the size of the valve that has to be fitted. There are two types of valves which can be given, which is one is bioprosthetic, which is made of pig or bovine, or another is mechanical. As the name suggests, it's basically instruments and mechanical instruments. And the mechanical valve is normally it stays on for longer, it has more durability than a bioprosthetic one, but a patient who takes in a mechanical one will have to live on anticoagulant and blood thinner for their life. And the surgeon will start by putting one suture into each corner and fill in between. So this is done circumferentially, as you can see, and this is the annulus right over here, and it is done around the annulus. Now pledget would be added on suture for extra support. The valve is now ready to be placed and the sutures are passed over the swing ring of the valve. There would be a swing ring in the valve and the sutures would be passed over them. The valve would be lowered and then the sutures would be closed and they will be tightened. Any extraneous material such as extra suture linings would be removed and the aorta will be closed using a two-layer closure, which means there would be a first layer involved and a second layer of suturing as well. In the first layer is usually done to bring the edges together, and the second layer is basically the hemostatic layer or the main layer which prevents from leaking with multiple simple stitches. The cross clamp, once removed, the heart starts beating and blood starts flowing back. And the surgeon now will check for ventricular fibrillation or if the heart is beating irregularly or not. If the heart does beat irregularly, then an electric shock would be given and so that the heart starts beating normally, and then the tubing would be systematically removed, the sutures would be tied and cleaned, and the peritoneum would be closed. Now let's talk how about the closure, which is the final stage. Local anesthesia is given before the closing in the cavity that was open. You place sterile swabs between the sternum. You place wires around the sternum, and this is critical that you stay. It is quite critical that you stay close to the sternal bone as possible, so as to not damage the soft tissues around it. And you start caudally, which means towards the tail, and progress towards the front. And you'll start by clipping the loose ends of the wire, and then you'll cut the loops of the wire and cover newly exposed ends with swab. The swab would be removed from beneath the sternum. You'll inspect the wire holes for bleeding. If bleeding does occur, then additional sutures might be given. Cross loose ends of the wire is contralaterally end of the wire is tightened contralaterally in a horizontal plane such as this over here, and the wires are pulled to close the sternum just like a surgical knot. And you trim the wire ends to about 1 centimeter and check. You pull upward and then twist, and then you bend the wire stumps so that it doesn't interfere with your soft tissues and it doesn't damage them again, and so there is no chances of infection. Now you close the soft tissue with vertical sutures closing the deep layer with vertical sutures and horizontal sutures to close the superficial layer. So again, a two-layer surgery. Now let's talk about post-operative care. There might be complications involved like any other surgery such as infection, bleeding, irregular heart rhythm, complications from anesthesia, blood clots, leading to stroke or heart attack. But heart attack normally occurs in about 1% of the population, so there's nothing to fear. Post-operative care at the hospital would basically, the patient once after the procedure, they will find themselves in an ICU where they would be monitored intensely, and the surgeons will look for vital signs such as heart rate. A breathing tube would normally be attached, and the person would not be able to talk. A chest tube is used to drain the excess fluid from your chest. A small temporary pacemaker wire exiting from your chest is used, and this might lead to soreness. A breathing therapy is normally recommended and it is definitely given so as to remove fluids that are collected in your lungs during the surgery. You might also receive elastic shocking to help blood circulate through your leg veins. You will have to avoid food and drink for some time unless and until you're able to handle it. You might be discharged within 5 to 6 days. Normally it takes about 1 week. At home, you should always check your temperature regularly. If it was a mechanical valve replacement, then you have to take your medicines frequently, which includes anticoagulants and blood thinners, such as apixaban. You should avoid lifting anything heavy for several weeks. You should take up a follow-week appointment with your surgeon, and this is the appointment where any non-absorbable stitches will be removed. Now on to the references. Thank you very much for waiting on. Thank you.